Welcome to a talk by the Colorado College Biochemistry 2 class of 2020. I'm your host, Leo Braschel, and I'll be walking you through our presentation. Before I begin, I'd like to thank the Southern Colorado Health Network for partnering with us on this presentation. I also want to thank and acknowledge funding from the Colorado College Student Government Association and the Colorado College Science Outreach Club, of which I am a chair. Finally, this would not have been possible without the support and encouragement of our professor, Dr. Nina Grover. A quick overview of what is to come. First, we'll talk about some basics of HIV infection, what it is, who can become infected, and how. Then, we will take you through an overview of the viral life cycle, followed by some ways to inhibit viral replication. To begin, let's discuss the basics. What is a virus, and how does it differ from bacteria? Most of you have encountered viruses in one form or another, from influenza to the common cold. Viruses are the smallest carriers of genetic material and cannot replicate on their own, meaning viruses can only reproduce inside of a host cell. Many scientists do not even consider viruses to be alive, since they are unable to reproduce without a host. Bacteria, on the other hand, are capable of living and reproducing outside of a host, and are definitely alive. Viruses come in two types. A traditional virus carries DNA, and a retrovirus carries RNA, which can become incorporated into the transcript of a host cell. It will be copied by the cell's machinery and currently can only be treated and not cured entirely, because it becomes a part of us. HIV is one such retrovirus. Why do so many people dedicate their lives to the study of viruses? Well, much like human beings and other forms of life, viruses are capable of evolving and have evolved alongside us since the beginning of time. Additionally, the study of viruses makes it easier to combat new viruses as they crop up. Take the coronavirus. If some people were not already well versed in the field of viruses, we'd be starting from scratch. So, defining HIV-1 and AIDS. HIV stands for Human Immunodeficiency Virus and infects human T cells, which are a major part of our immune system. HIV virions meaning individual virus particles, recognize a receptor on T cells called CD4. HIV is diagnosed based on viral load, which is the accumulation of virions in the bloodstream. We'll talk more about testing later in the presentation. AIDS stands for Acquired Immunodeficiency Syndrome. It is the final stage of HIV infection. Not everyone that has HIV will reach this stage if it is treated adequately. AIDS is characterized by a severe depletion of T cell count, those cells of the immune system that HIV targets. It is also characterized by the cropping up of many opportunistic infections. This refers to infections that may not have normally affected someone, but are able to take hold because of the compromised immune system. This could be anything from cold sores to pneumonia to cancer. So, HIV then. HIV was first recognized as an epidemic in the early 1980s, when the CDC, Center for Disease Control, began reporting on clusters of cases of opportunistic infections and cancers, such as Kaposi sarcoma, that were springing up in communities around the country, primarily in gay men. As similar symptoms became recognizable between cases, this epidemic was termed GRID, gay-related immunodeficiency, and the stigma intensified in the healthcare industry, in the workplace, in schools, and interpersonally as well. In 1983, the CDC defined the onset of opportunistic infections and cancers due to immunocompromised AIDS. In 1894, HIV was determined to be the underlying cause of AIDS. Although deaths were still on the rise, no treatment was available, and a diagnosis of HIV was equivalent to a death sentence. In 1987, AZT was released as a drug to delay the progression of HIV to AIDS. At the time, AZT was the most expensive drug in the market and had severe side effects and high toxicity. Activist groups such as ACT UP pushed for more accessible treatment and a stop to discriminatory behaviors against people living with HIV. Throughout the 1990s, activism continued, as did the international fight to combat rising new HIV infections and AIDS deaths, as more antiretrovirals were produced and treatment became more effective and with decreasing side effects. The introduction of PEP and PrEP aided greatly in the turning of this tide, and we will talk more about these later. 2007 was the first year that saw a decrease in AIDS deaths compared to the previous years since the epidemic began. Moving forward, prevention has been determined to be key in preventing new infections and the spread of HIV, as well as accessible ARV treatment. So, HIV now. To date, 75 million people have been infected with HIV, and 39 million have died of AIDS or HIV-related illnesses. However, today, a diagnosis with HIV no longer means a death sentence, as people living with HIV can lead long lives with consistent treatment. 37.9 million people are estimated to be living with HIV as of 2018. However, only 79% of people living with HIV are aware of their status, thus risking the transmission of the virus to others without their knowledge. Although adherence and access to treatment is incredibly successful in preventing the progression of HIV to AIDS and preventing a transmission, only 3 out of 5 people living with HIV are on antiretroviral therapy, and only 53% of people living with HIV maintain an undetectable viral load. This is largely due to existing health inequities and the lack of accessible healthcare and treatment options globally. As depicted on this slide, a goal that many cities have committed to is known as 90-90-90, which strives for 90% of people to know their HIV status, 90% of those that are HIV positive to be on treatment, and 90% of people on treatment to be satisfactorily virally suppressed. Next, HIV transmission. The transmission of HIV can only occur through 5 different bodily fluids. These are blood, seminal fluids, such as semen and pre-seminal fluids, vaginal fluids, rectal fluids, and breast milk. In order to transmit HIV, these 5 fluids have to make contact with either damaged tissue exposing the fluid to the bloodstream, or mucous membranes, which are found in the walls of the rectum, vagina, penis, and the mouth. The most common ways that HIV is transmitted is through unprotected sexual intercourse and using dirty needles. It is also worth noting that a mother can also transfer HIV to their child during birth if the blood of the mother and child is mixed. There are ways to prevent this transmission, and so HIV-positive women can still give birth to a child without HIV. Additionally, breast milk can infect a child, and so to prevent this, an HIV-positive mother will often not breastfeed. So, HIV is not transmitted by certain bodily fluids. This includes saliva, sweat, tears, urine, and feces. This means that HIV will not be contracted by kissing, hugging, sharing food, toilet seats, coughing, sneezing, or by water exchange when bathing or swimming. Furthermore, a common misconception is that insects like mosquitoes can transmit HIV because they interact with blood. In fact, insects cannot transmit HIV because insects cannot get infected. The HIV virus only infects humans. Also, insects do not exchange blood with their host, and the virus is not found within their saliva. Why is HIV only transmitted by 5 fluids? HIV is only transmitted by fluids that contain virion particles. The virus specifically recognizes and affects CD4 T cells, and therefore, many fears associated with things like kissing and insect bites are generally misfounded. Furthermore, even within these 5 fluids, if the viral load is undetectable by the threshold of certain tests, then it has been shown to not be transmittable. This is exciting because it means that if treated properly, people living with HIV can still practice safer sex and maintain the health of their intimate partners. How to avoid transmission. Generally, for avoiding transmission, safer sex and clean needles are best practice. There is no such thing as safe sex, but the use of condoms and adequate communication between you and your partner about HIV or other STI status are important steps to take. Additionally, if you fear that you may have come into contact with HIV, PEP is a treatment that stands for post-exposure prophylaxis and has been shown to have the potential to stop the virus from ever taking hold within your body. Finally, more and more states are approving clean needle and syringe exchange programs that can help minimize the risk from sharing needles with others. In general, it's really important to minimize blood-to-blood contact with others. HIV-1 creates immune suppression. Primary HIV infection is 2 to 4 weeks after contraction. It is characterized by a high viral load. HIV infection has been spread more easily during primary infection than later stages. The timeline that follows on this slide is based on untreated HIV-1 and its progression to AIDS. The clinical latent infection, which can last up to 8 to 10 years, is what follows the primary HIV infection. This stage can last for a long time if not receiving antiretroviral therapy. Some people develop more severe diseases much sooner. Many people can be in the latent stage and be completely asymptomatic, risking the infection of other people because they don't know their status. Some specific nutrient abnormalities can also occur in these earlier stages of HIV-1, resulting in malnutrition that will really show itself in later stages of the virus. As the virus continues to multiply and destroy immune cells, a person living with HIV may develop mild infections or chronic signs and symptoms as listed. So, immune suppression and progression to AIDS. AIDS occurs when the immune system has been severely damaged. This is quantified when the CD4 T cell count is below 200 millimeters cubed of blood. A person living with HIV is more likely to develop opportunistic infections or opportunistic cancers, as discussed earlier. This is more likely at this stage due to the severely decreased immune response, which is often the lethal factor of AIDS. Symptoms are like those listed on the previous slide, but are often more severe. As of 2018, 1.1 million people in the US were living with HIV. 37.9 million were living with HIV globally. Fortunately, 53% of all people living with HIV-1 are virally suppressed, and rates of infection are now relatively stable, as depicted in this chart. There is hope that these numbers may even begin to decrease in the next few decades. At this point, many people do not progress to AIDS, but many still do in areas that lack adequate healthcare and awareness. So, don't be afraid to get tested. As was stated, an estimated 1.1 million people in the United States have HIV, including about 162,500 people who are unaware of their status. Nearly 40% of new HIV infections are transmitted by people who do not know they have the virus. For people with undiagnosed HIV, testing is the first step in maintaining a healthy life and reducing the spread of HIV. Everyone should be tested at least once. Those that participate in riskier behaviors, such as having multiple partners or unprotected sex, may benefit from more frequent assessment. We shouldn't be scared to get tested. It can inform us in making healthy decisions for ourselves and those around us. It makes sense to shy away from the label of HIV, but we live in a time where people can live full lives even with the virus instead of dying from it prematurely. So, testing options. There are 3 types of HIV tests. NATs, nucleic acid tests, look for the actual virus in the blood. They can be used the earliest, but they are also very expensive and not routinely used for HIV screening unless the person recently had a high-risk exposure or a possible exposure with early symptoms of HIV infection. Next, antigen antibody tests look for both HIV antibodies and antigens. Antigens are foreign substances that cause your immune system to activate. HIV proteins are an antigen. Antibodies are your immune system's response to these antigens. Tests to detect both antigen and antibodies are recommended for testing done in labs and are now common in the United States. Antibody tests detect the presence of just antibodies. Many rapid tests and home tests are antibody tests. An initial HIV test usually will either be an antigen antibody test or an antibody test. If the initial HIV test is a rapid test or a home test and it is positive, the individual should go to a healthcare provider to get follow-up testing. If the initial HIV test is a laboratory test and it is positive, the laboratory will usually conduct follow-up testing on the same blood sample as the initial test. Although HIV tests are generally very accurate, follow-up testing allows the healthcare provider to be sure the diagnosis is right. Where to go? You can get tested for HIV and other STDs at your doctor's office, a community health clinic, the health department, or your local Planned Parenthood health center. There can be anonymous or confidential options depending on the state you live in. Be sure to educate yourself. It's usually just a quick Google search away. Ultimately, however, it is a priority for the state to keep close track of the levels and spread of HIV in the community. Next, HIV entry, infection of the cell. To gain a deeper understanding of the HIV virus, we will briefly go over the mechanism behind its infection of the cell. As shown on the slide, there are 4 general processes involved. When the virus is introduced into the body, it goes on to interact with its target cell through specific and nonspecific means. Once it binds to the cell surface, it is in close proximity to the primary receptor, CD4. As mentioned earlier in the presentation, these receptors are found on the surface of T cells, which are the primary target of HIV. After the virus particles form favorable interactions with both the cell membrane and the primary receptor, it must then interact with either co-receptors CCR5 or CXCR4 to facilitate a structural change in the envelope protein found on the virus membrane. This structural change is then able to cause the fusion of the HIV membrane with the cell membrane. We can watch a short video illustrating this process. The first thing that you're going to see here is a size comparison of HIV and the host cell. The HIV virion particle is on the left, and the host cell is depicted on the right. Interaction with the cell membrane brings the virus into close proximity to primary receptors, CD4, which are depicted in yellow. Upon interacting with CD4, HIV next interacts with co-receptor CCR5 or CXCR4, which facilitates a conformational change in envelope proteins found on the HIV particle surface. Co-receptors are shown in orange and envelope proteins are shown in blue and red. Ultimately, this conformational change facilitates the fusion of the virus membrane with the cell membrane. This conformational change, introduced by the interaction of the primary receptor and co-receptor, exposes the hydrophobic domain of GP41. The fusion peptide component of GP41 facilitates tethering to the cell membrane and subsequent formation of the 6-helix bundle, which creates a pore between both membranes that allows the uptake of the viral RNA. Next, reverse transcription. After entry, reverse transcription is the transition from viral RNA to DNA. If you remember from earlier, HIV is a retrovirus and it incorporates itself into the host's genetic DNA code. Reverse transcription is important so that the HIV-1 genetic code is essentially in the same language as the host genetic code. This process is performed through something known as reverse transcriptase, shown in this diagram, copying the HIV RNA in green, the HIV DNA in orange. Next, integrase. Now that HIV has created the viral DNA, it is ready to be incorporated into the host genes through a process called integration. First, the viral DNA travels into the nucleus, a body that houses the host's DNA. Once the viral DNA enters the nucleus, integrase, another enzyme, comes and facilitates the incorporation of viral DNA into host DNA. This process is important because now every time the infected T cell replicates, the viral DNA is also replicated, producing viral RNA and HIV proteins. These components are packaged and assembled to then leave and infect other T cells. Next, HIV assembly and budding. Once HIV-1 virus affects T cells and makes all the proteins it needs, the next thing it does is collect and package all of its protein components and genetic material so it can bud out of the cell to infect other T cells. HIV-1 virus has one genetic copy and makes 15 proteins from that. And initially, when these proteins are made, they are bonded to one another in groups of 2, 3, or 4, rather than found separately. During assembly, one of these complexes of proteins first goes and attaches itself to the surface of the cell using specific signaling machinery. Then, the other proteins in the genetic material will come and bind to the protein that first got attached to the membrane. Once the necessary components are packaged, the proteins on the surface will interact with one another, forming a viral particle and budding out of the cell. Initially, when the virus buds out of the cell, it is an immature virus. However, using a protease enzyme that can act as a scissor, it will cut the bonds that connect the grouped virus proteins and allow the virus to mature. Now, the virus is ready to go and infect another T cell. In review, moving forward, it's crucial that we have a clear understanding of viral life cycle to understand where drugs can target. To recap, the main steps of the viral life cycle include viral entry into the host T cell, reverse transcription of viral RNA into viral DNA, integration of viral DNA permanently into the DNA of the infected cell, copying of the viral DNA into RNA, creation of new viruses, and the subsequent maturation of those viruses. Next, we'll discuss the immune response to viruses and inhibitors of different points of the viral life cycle. So, the immune response. When the virus infects a cell, the body has a couple of potential responses as a defense. These responses rely on two things: recognition and communication. In the context of T cell infection in HIV-1, both recognition and communication are accomplished through structure. One potential immune response centers around communication, in this case, through the surface of the cell. To communicate what is happening on the inside of the cell through the cell surface, proteins from within the cell are constantly broken down and displayed on the surface of the cell. It is important to note that the cell surface is not smooth, as is usually presented, for example, in the top left of the diagram. Rather, the surface is populated by thousands of structures for recognition, communication, and other functions. If an abnormal, in this case a viral protein, is presented at the cell surface, then other cells and proteins might be recruited in order to deal with it. This may result in the production of antibodies, which are structures that allow for future recognition of a specific viral protein. The lower left image is a rendering of antibody structure. The two upper lobes of the structure are where the viral protein binds. After the chain of interactions for antibody production, the cell displaying the viral proteins may be destroyed, or other proteins may be recruited to the infected cell for additional response. Next, another pathway of immune response depends on proteins which recognize retroviral reverse transcriptase, which we've discussed previously. These proteins bind to and then mutate the viral RNA. Specifically, cytosine in the viral RNA is converted to uracil, as you see in the structures marked C and U in the figure. This functions similar to switching keys on a keyboard. If several letters are exchanged in a message, key portions of the message may be insensible, or the entire message may no longer convey what was intended. This follows a central theme that changing structure leads to reduction or inability to function. However, mutations can also benefit the cell, and this immune response is partially responsible for HIV-1's high mutation rate. This mutation rate results in HIV-1's rapid development of resistance to therapies. One other mode of defense involves tethering the virion to the host cell so that it cannot infect other cells. This is facilitated by a series of host cell proteins which are incorporated into the virus as a buds and ultimately become a part of the virion's membrane. We're not going to go into that very much here, however it's important to recognize that pathway. These three pathways for defense are effective, but ultimately insufficient to prevent viral replication. We're going to go into some inhibitor examples which complement the immune response and target other portions of the viral life cycle. So first, we have talked about the HIV and how it works. Now we move on to talk a little bit about the various types of medicines. Inhibitors target specific steps in the HIV life cycle and block the virus from being able to do what it needs to do. Entry inhibitors are a type of antiretroviral drug that target the first two steps of the HIV life cycle and prevent the virus from entering the host cell. This type of inhibitor has two potential targets: the binding of the HIV cell to the proteins on the surface of the host cell and the fusion of the two cell membranes. One example of an entry inhibitor is Fusion. As the name suggests, it inhibits the fusion of cell membranes, which in turn prevents the virus from entering the cell. It does this by mimicking components of the HIV machinery, blocking the conformational change that needs to occur for the two membranes to fuse. Unfortunately, Fusion costs $25,000 per year and requires 2 injections per day. Almost all patients have some kind of reaction to the injections as well. Side effects range from common symptoms like irritation and pain at an injection site to serious issues like weight loss, numbness in limbs, and even vision changes. For these reasons, Fusion is used as a salvage therapy, meaning it's like a last resort for patients when all other treatments have failed. Next, reverse transcriptase inhibitors, preventing virus from making copies. The goal of reverse transcriptase inhibitors is to prevent the virus from making copies. We accomplish this goal by stopping the viral RNA from becoming viral DNA, which, if you recall, is the role of reverse transcriptase. The reason for this is because it is viral DNA that gets into our genome and becomes a part of the cell's genetic material. So, looking at this image, the point we are targeting to prevent the virus from making copies is marked by a red X. There are two classes of reverse transcriptase inhibitors. They are NRTIs and NNRTIs. Essentially, both these classes provide nucleotide analogs for the reverse transcriptase enzyme. These nucleotide analogs end up jamming the process of making DNA copies of the viral RNA genome. In short, the building blocks are mutated so they can no longer connect, stopping the formation of the viral DNA. An example of such an inhibitor is emtricitabine. Emtricitabine has to be prescribed by a physician and can only be taken orally as a tablet or solution once per day. The price of this inhibitor ranges from $537 to $664 per month. The most severe side effects are diarrhea, headaches, and rashes. Next, integrase inhibitors, preventing the virus from making copies. The next class of inhibitors are integrase inhibitors. The goal here is to prevent the integration of viral DNA into the host cell DNA, ultimately going forward to copy itself and form new virions in the host cell's machinery. With these inhibitors, we are able to prevent viral DNA from getting into our genome. This step can be seen in the image above at the point marked with an X. These inhibitors target the active site of integrase, the enzyme responsible for this process. The two classes of inhibitors are polyanions, which mimic the DNA structure that integrase usually binds to, and DKAs, which target the integrase enzyme's active site. An example of such an inhibitor is raltegravir. It also has to be prescribed by a physician and can be taken orally as a tablet or solution twice per day. Drug cost ranges from $1,500 to $1,800 per month. Side effects include nausea, headache, trouble sleeping, fatigue, and mood changes. As we talk about inhibitors, one concept to keep in mind is drug resistance. Inhibitors are designed to target certain proteins and processes of the viral life cycle. That being said, some viruses can change the binding site of these proteins via mutation, therefore making these drugs less effective. We'll talk even more about mutations soon. Protease inhibitors. As we talked about earlier, once the virus buds from the host cell, viral maturation by HIV-1 protease occurs, which produces mature infectious viruses. Protease is a type of enzyme that catalyzes the breakdown of specific bonds in protein, like scissors. HIV-1 protease plays an important role in producing mature and functional proteins such as viral capsids, reverse transcriptase, and integrase. Protease cuts at different sites on the Gooch proteins, thus producing functional proteins. Therefore, a series of drug inhibitors have been designed to target the protease itself. Protease inhibitors are designed to block protease function by binding the protease so that it can't work on its intended target. Protease inhibitors are taken orally in tablets. One example of these inhibitors is called saquinavir and was introduced on market in 1995. It also marked the beginning of combination treatment for HIV, a common practice that I'll discuss shortly. Side effects of saquinavir include cold symptoms, chest pain, increased fat in the neck and chest, urination, weight loss, cough, and nausea, among others. In general, the price is considerable for inhibitor drugs, while side effects can be severe. Sticking to schedule is also important to prevent resistance. This all amounts to a very exhausting and taxing process. Mutations in HIV-1 cause drug resistance. Before talking about combination therapies, I want to revisit the idea of mutations and drug resistance in HIV-1. As HIV multiplies in the body, mutations can occur that can cause HIV to become more resistant to drug treatment. Most of these mutations arise as a result of certain components in our body's immune system that purposefully mutate the HIV in an effort to try and deactivate the virus, as discussed previously. However, a lot of the time these components inadvertently and stochastically cause mutations that are beneficial to the virus itself, such as drug resistance. Because of these components, HIV has a very high mutation rate compared to other viruses, which make vaccines and anti-HIV drugs much harder to manufacture. It is important to note here that there are many different strains of HIV. Some are more resistant to drugs than others, meaning treatment regimens vary from patient to patient. Next, combination therapy and HAART. Now let's talk about combination therapy approaches. HAART stands for Highly Active Antiretroviral Therapy. HAART is the combinatory use of entry inhibitors, reverse transcriptase inhibitors, integrase inhibitors, and protease inhibitors to mitigate the likelihood that HIV-1 will develop multi-drug resistance. The guiding principle of HAART is that multiple mutations would have to arise in the virus simultaneously in order to confer resistance against all the classes of drugs. Mutations that lead to immunity against one drug will not make the virus immune to all the other drugs. Mutations that confer resistance against one class of drugs are nullified when a patient is on a multi-drug regimen, because other key steps in the viral life cycle are inhibited. That is to say, other medications prevent viral replication. Next, future directions, prevention. The future directions for HIV prevention are twofold: active prevention by people and the development of vaccines. One current approach to active prevention is the use of PrEP, which stands for pre-exposure prophylaxis. This is taken before exposure to HIV even occurs, and daily PrEP use can reduce the risk of sexually acquired HIV by more than 90%. Along with other prevention methods like condoms, PrEP can offer great protection against HIV if taken consistently. However, the need for this consistent regimen, as well as the associated cost, keep it from being a reasonable approach for all populations at this point in time. Next, future directions, vaccines. In terms of vaccines, it would be stellar for the elucidation of a vaccine that stayed consistently effective against HIV, or even as effective as, say, annual flu shots. The mutation rate of HIV provides a great barrier to the development of this sort of preventative measure. Though there are no current HIV vaccines available, the quest to develop a preventative HIV vaccine was reinvigorated in 2009, and results from the large RV144 trial showed that for the first time, an investigational vaccine regimen could confer a modest degree of protection against HIV infection. The RV144 trial was performed in Thailand with a population of 16,000 people and showed a decrease in infection by 31%. Successful vaccines could greatly reduce transmission, could replace HIV medicines, and could greatly reduce the number of HIV cases that advance to AIDS. Thank you for listening to this presentation, brought to you by the Colorado College Biochemistry 2 class of 2020. If you have more questions, don't hesitate to contact organizations like Planned Parenthood